Hi guys, once again Ijaz Hidayat is with you with new talk and with new discussions, and today we have question from Talha Fakhruddin. He's one of my follower, is my subscriber, and those who are watching my this video, if you like and you want to learn more, please like this video, share this video, especially among your community. And today we're going to take a question by Talha Fakhruddin. So Talha Fakhruddin question is, if we having the patient with the chronic hypertension, kidney are used to with a high blood pressure and it's producing very good urine output, and do we need to keep the mean arterial pressure during the bypass in a higher side, like above than 80 millimeter mercury? Can it going to affect the surgical feed during the surgery for the surgeons? And what are the physiological complication of keeping higher mean arterial pressure above than 80 millimeter per mercury? So this is the question by Talha Fakhruddin. Very interesting questions, and we will try to elaborate, and we will going to highlight some good points as a perfusionist, as we are the perfusionist, and as we all know that usually we converts pulsatility flow into the non-pulsatile flow. So as you know, once you give the heparin to the patients and the surgeon cannulated the patients, and we initiate bypass and we convert this pulsatile flow into the non-pulsatile, and we lost systolic and diastolic pressure, and we are getting only the mean arterial pressure. And usually as a perfusionist, we are keeping pressure around like a 50 to 70 millimeter mercury in a normal patient's cases. But here the scenario is too different. Like we have the chronic hypertension patients, whose kidneys are also used with the high blood pressures. So as per the Talha Fakhruddin questions, do we need to keep higher blood pressures, like a mean pressures like above than 80 millimeter mercury? As per him, can it be a beneficial for the rest of the organs by perfusing good with the high pressures? And do it will going to affect the surgical feed for the surgeon if you are keeping high blood pressures? And what are the complications and physiological complications by keeping high blood pressure above mean pressure above than 80 millimeters? So we'll going step by step. As you know, as we are the perfusionist, and you know, we are keeping the pressures around 60 to 50 to 70 millimeter mercury. But these type of patients who having the chronic hypertensions will try to keep the pressures like 70 to 80 millimeter per mercury. And to keep these pressures, sometimes you need to start some vasopressors, like you are using the norepi or a phenylephrine to keep the pressure around 60 to 70 to 80 millimeter mercury. Don't go below than the 60 millimeter mercury. The patients like having chronic hypertension disease, to try to avoid high blood pressures above than 80 millimeter mercury, because if you're keeping high blood pressure, there is a chance of cerebrovascular disease, renal insufficiency, carotid stenosis. So keep the pressures like 70 to 80 and don't go above than 80. If you hypernize the patient and our bleeding point is higher on a cardiopulmonary bypass, so 3 times higher than the baseline actually. Yeah, like for example, your baseline ACT is 120 second or 150 second, but you're keeping the ACT above than 480 second or above than 400 seconds. So it's when the bleeding point is the higher side, and you already stop the heart. The more microvessels are on the heart or in the brain, and there is a chance of bleeding with high anticoagulations. There's a chance of hemorrhagic. So to avoid all these type issues, to keep the pressures like a 70 to 80, not go above than 80 millimeter mercury. This is my personal recommendation as my personal experience. If you are running your perfusion with the low pressures, try to titrate to the end organ perfusion markers, like start your vasopressins or start some phenylephrine drug to keep the pressure like a 70 to 80, and focused on your urine output to keep 1 cc per kg per hour. Your urine out should be there. Keep your lactate in your normal ranges. So it is the marker to keep you are perfusing very nice, adequate perfusion to the body, and keep the cerebral sets on, and keep the cerebral saturation above than the 50, even right or left. This is my personal recommendation. You can share your experience even here. If you're keeping higher blood pressure, there is a chance of your surgeons get affected in the surgical, the bleeding side, and there is a chance of the coagulopathy even. So avoid, for time being, you can decrease your flow to keep the surgical field not a messy. So surgeon can work on that, and even you can decrease the high temperature to avoid more bleeding in the surgical side. We keep the pressures like 70 to 80 millimeter per mercury. This is question of Allah. So my recommendation is to keep pressure 70 to 80 millimeter per mercury. Titrate your pressures to keep by using Norapi, or you can use phenylephrine. Always focused on your lactate. Lactate should be in the normal ranges, and your cerebral sat should be around like a 50 to 60. So this is my personal recommendation for the question as per Talha Fakhruddin, that in a patients like a chronic hypertension, how we going to manage on a heart lung machine. So the second question is by Haris Rahmania. Haris Rahmania's question is if our FIO2, as the question by the Haris Rahmania, FIO2 is indirectly proportion. So when we decrease, our PCO2 is more on a bypass, like on a cardiac heart lung machines, and do we need to decrease the FIO2 and increase the sweep gas, as FIO2 is in the indirectly proportions. So FIO2 and sweep gas flow are separate control. As first of we need to understand, first of all we need to understand the concept of FiO2 and the sweep gas. FiO2 is fractional inspired oxygenations, which we are going to maintain the oxygenation of the body. Sweep gas flow is controlling and it is a help to removal of the PCO2. So removal of the PCO2 we are using like sweep gas flow. So in case your PCO2 is higher on a pump, so as I already mentioned, there is a formula: present PCO2 divided by desired PCO2 into the present gas flow. So by using that formula, you can adjust your PCO2. So there is nothing to change your FiO2, because if you are going to change the FiO2, maybe by increasing your FiO2, there is a chance of oxygen toxicity. So our target is to keep the PO2 is around like 200 millimeter per mercury, and PCO2 in the range of the 35 to 45 millimeter per mercury. So FiO2 and sweep gas flow are the separate control. FiO2 adjusts O2 delivery. Sweep gas flow adjusts only to CO2 removal. So if your CO2 is higher, you can increase your sweep gas. If your PCO2 is on the lower side, you can decrease your sweep gas. So FiO2 is not inversely proportional to the PCO2. Okay, so make it clear. FiO2 is not inversely proportional to the PCO2. No, decreasing FiO2 does not increase your PCO2 fall. So keep in your mind that they both have the different functions. Sweep gas is used to control the PCO2 level. FiO2 controls your PO2 level. So always ensure adequate PO2 before reducing the FiO2. So if for example, your PO2 is 150 on a bypass, and if you decrease your FiO2, they will going to decrease the PO2 of the patient. So don't compromise your PO2 of the patient. And sometime your PCO2 is like, for example, 60, and you increase the so your PCO2 is like a 30. So you need to decrease the sweep gas. As per your question, then we have to increase the FiO2. Your already PO2 is like a 300, and by increasing the FiO2, you are going to increase the more PO2 to the patient. And especially for the long bypass, it can create, it will cause oxygen toxicity. to avoid oxygen toxicity. So focus your PO2 with the FiO2 management, and focus your PCO2 management with the sweep gas control management. So if the PCO2 is higher, as I mentioned, if the PCO2 is higher, FiO2 can be safely reduced to avoid oxygen toxicity during the long run bypass, I already mentioned before. So PCO2 is managed with the sweep gas. So it's as per what I understand from your questions, as you mentioned in your question, that FiO2 is indirectly proportion. So when we decrease PCO2 is more FiO2, and when we PCO2 is more, we decrease FiO2 and increase sweep gas. So both have the different, it depend on the scenarios. So if your PCO2 is higher, you just focus with the sweep gas flow. If your PCO2 is lower sided, just play with the sweep gas flow. If your FiO2 is decreased, so as per my study, as per my experience, by increasing 10% of your FiO2, you are going to increase or decrease 40 to 50 millimeter per mercury of the PO2 gas. So for example, your PO2 is like 150, and you want to keep your partial oxygen pressure on a hard leg machine for the blood gases, you want like a 200. So by increasing your 10%, so for example, your FiO2 was on a 60%, and your blood gas is showing PO2 150, and you want to keep the PO2 around 200 millimeter mercury. Now you can increase from 50% FiO2 to 60% FiO2 to 70%. By increasing 70%, by increasing 10% of the FiO2, you will see there is a different change. Your PO2 will increase to 200. So each 10% will going to increase your 40 to 50 millimeter mercury of your PO2 with the blood gases. So I'll try my best to answer you, Mr. Haris Rahmania. So PCO2 pressure is the lower, and you need to increase the PCO2 level on a blood gas. You can decrease your sweep gas flow to increase your sweep gas, to increase your PCO2 on the pump. So guys, at the end, if you like the video, please share, press the icon button, and I love to answer to your questions. I'm so happy that you are maintaining the continuity of the questioning to me, and I'll try to answer as much I can. At the end, have a nice good day, take care.